thank you guys for coming today in this episode of EMS Training with Josh and Rick. And we're going to go through and kind of review the Pediatric Advanced Life Support, part of what's going to go on, the written test, part of what's going on with our mega codes, and then just to give an opportunity to pick your guys' brains today on what it is that we do for our pediatric patients. So thank you guys for giving up your day. Now you're getting paid. So starting off with high quality BLS, I said last year during the review of PALS that AHA science found that even with all the drugs and all the interventions that we do, that high quality CPR and early defibrillation is what's going to help lead to better outcomes for these kids. If you guys don't mind going over, hey, why do we start CPR at a heart rate of less than 60? Like, what's the purpose of that?
Yeah, so the heart rate for pediatric patients, remember, is typically going to be higher than your adult patients. So 60 is bradycardia in your adult patients. For pediatric patients with signs of perfusion, that's important too to remember that they have to be shocky looking. Then we're going to be starting CPR.
So just to interrupt you real quick.
Yeah, no, but
So if your kid is a 11-year-old that's sitting in a chair that says that they just don't feel well, and you do a check and their pulse rate's 56, we don't necessarily have to start CPR at that point.
right, we're looking at signs of poor perfusion.
Okay.
So whether it's addressing their cap refill, obvious signs of cyanosis, central cyanosis, things like that is what we're going to be looking at for that heart rate. 60 in those signs, and then we're going to be starting CPR.
Okay. And then a big difference on the adults and the children is if we come up on a kid that's down and we identify that they're in cardiac arrest and we don't know how long they've been down, they want us to go call 911 and get an AED after we've done 2 minutes of CPR. Why is that in there? Do you know, Rick?
To be honest, I don't know why that's in there.
Okay.
Why do we do the 2 minutes of CPR?
Yeah, so
And if I were to speculate, and Josh, correct me if I'm wrong, but it's to ensure that you're not delaying CPR in order to go call 911 or to go get an AED.
Okay.
It's to ensure that you have hands on that patient's chest as soon as you recognize that there's a problem, and then you can, while you're doing CPR, try and coordinate calling 911, going and getting an AED, and doing those other things that obviously are part of the chain of survival: early recognition, early CPR, early defibrillation, early activation of 911.
okay.
Making sure all those things take place, but I really think the emphasis is getting your hands on the patient's chest and starting CPR.
So early CPR and understanding that for the test, yes, we're going to say if it's unwitnessed that we're going to do 2 minutes of CPR.
Right.
But when we arrive on an engine company or a truck company, it's start CPR and get the cardiac monitor on them as quickly as we can. So you don't have to hit a 2-minute benchmark in order to do that defibrillation if it's called for.
And that's it.
When we're
I mean, so this class is made for anybody that's coming up onto a cardiac arrest. It says call prep. Well, we are the help, right? So in this situation where it's a witness arrest, you can leave the patient to go get your AED because early defibrillation is going to be key, okay? And they're somewhat relying on their oxygen reserves that they have left in their system. With the unwitnessed, you don't know how long they've been down at all. So go ahead and do your 2 minutes of CPR, try to get some perfusion going, try to get some oxygenation, and then get your AED. That's where that all stems from.
On kids is the only time in AHA now that we see a change on our compression to ventilation ratio. So just to remind everybody on that if it's one rescuer, so if we come up on somebody, whether it's this kid here or the infant, we're going to do 30 and 2, minimizing compressions and not spending over that 10 seconds for a pulse check. When we go to the 2 rescuer, then we're going to do more ventilations and go down to a 15 and 2. It says on there the advanced airway, we're going to do our 100 to 120 compressions a minute with a breath basically every 6 seconds or 10 per minute. Does our king airway count as an advanced airway? So if we get on scene and we put in a king, are we okay then to then transfer over into our pit crew style where we're going to do 20 compressions and then a breath?
Yes.
Yeah, I would agree.
Okay, so we can keep that consistent, just knowing that that's the real world, taking care of real patients, And I'm okay as an evaluator on the mega codes if you say, hey, we're gonna do pit crew now that we have a king airway in it and go into that. But just, I think everybody just needs to remember that when we're doing the PALS written test, that for 2 rescuers with a pediatric patient, whether it's a child or an infant, it's gonna be 15 and 2. But you guys agree that, hey, pit crew is still gonna be more efficient. We don't have to change the way that we've gone through and learned how to do CPR just because it's now a 22 kilo kid. 30. Hand placement, again, that's going to depend on the person, on the child, or Josh, if you guys don't mind, since we have them in front of us, where that hand placement goes. So using one palm, you can go through and do it that way. And then a third of the depth of the chest. You might turn it to for the fine viewers at home. But it is going down into a third of the chest, about 2 inches. Again, the 2 inches is for the test. I think everybody that's going to be watching this has probably done some CPR tests and know about that depth, but full recoil, all of those things. One big difference is on the infant. We like to do the 2 thumbs encircling, but that's when you have 2 rescuers. And the rationale behind that is that when you have 2 rescuers, you're not going to lose the time setting the child down and then going to ventilations because we want to keep those around that 10 seconds. So 2 fingers, it's the same 1/3 the diameter of their chest from front to back, or now down to about 1.5 inches, and then if Rick was helping, the 2 thumb encircling. So.
And I think it's really important too to remember, we talked so much about depth and we mentioned recoil. Recoil, allowing full chest recoil is just as important as depth. Allowing the chest to completely recoil means that the heart is filling to its capacity before we compress the chest again. So really making sure we're not taking our hands off in between compressions, but that we're allowing full chest recoil before we get the depth that we all know we need to get for children or adults.
Okay. And it's going to be tough because I think when we're dealing with patients that are this size, there's a little more stress involved with it. So it is easy to just start to pound away and not get that full recoil. So, okay.
1/3 the diameter.
1/3. So assisting ventilations. I know that you guys are a little bit known for capnography and ventilations and things of that nature. So how are we going to select that bag valve mask? How are we going to make sure that the airway is open? How do we need to package our patients, whether we're just taking care of a pediatric trauma patient versus now we have the pediatric cardiac arrest patient? So what are some differences there?
So as far as selecting the right BVM, we have to remember that when we're using a BVM, we're delivering a certain amount of volume into the patient's chest. So tidal volume is based on ideal body weight, which is calculated based on your height. And we need to really pay attention to not just the fact that we're delivering tidal volume, but we're increasing the pressure in their chest. And remembering that the heart is between their lungs, so the more air we put into their lungs, we're kind of giving the heart a bear hug. So you can have somebody at the head bagging, working against somebody who's trying to optimize cardiac output, doing chest compressions. So really paying attention to how much air you're delivering with each breath and selecting the right bag. I would say with a pediatric patient, if you're in between, do I pick a pediatric BVM or pick an adult BVM? I would probably lean more towards a pediatric BVM just because you're going to get the tidal volume that the patient needs and you're going to minimize the risk of giving them too much. So,
okay, so our adult BVMs hold 1,000?
Between 1,000 and 1,200 is what they're rated at if you squeeze them with 2 hands.
Okay.
If you squeeze them with 1 hand, that goes down to about 800, but it's still more than double what most adults need.
That would be my question, is how much air is in the normal adult cavity?
So normal tidal volume for an adult is somewhere between 400 and 500 milliliters.
Okay.
So these BVMs that we use on a regular basis, that we kind of underestimate sometimes, can deliver a lot of tidal volume, way more than what we actually need.
Okay, so undersizing the bag valve mask for a pediatric patient is not necessarily going to underserve them.
Not at all,
Okay.
not at all.
Actually might help them out a little bit.
Yeah.
And that rate for CPR is 1 breath every 6 seconds or 10 a minute. With rescue breathing, it's on the bottom of the slide, but then we're going to do 1 every 3 to 5 seconds. So if they still have a pulse and we're just rescue breathing, it's still, but I, again, think that it's easy to hyperventilate these patients because we get a little more nervous and a little more excitement.
Especially in a high risk, lower acuity, lower frequency type call like a pediatric.
Okay.
We need to really pay attention to how often and how much air we're delivering each time.
Okay.
So, and kind of going into positioning in kids can be somewhat difficult because of how large their head is, how large their tongue is in relationship to the rest of their body, and making sure that we get them in a good neutral position. Ideally, you would like the tragus of the ear in line with their sternal notch. So you're kind of wanting to maintain a neutral position. We think a lot of times we refer that sniffing position as just hyperextending their neck, and that's not really the case. We want to make sure we pad underneath their neck, pad underneath their shoulders, get their head in a good neutral position, and that minimizes the amount of air that goes down into their stomach, so thus minimizing the risk of vomiting, and it also allows a more patent airway, allowing the patient to ventilate easier when they're bagging. So really paying attention to patient positioning is important.
Okay. Josh, you have anything to add on that?
Just what the next one I was going to say, just ventilate till chest rise is seen. We don't need to be bagging. I think there were several people that had the opportunity to see the other dummy where we were talking about tidal volumes and just how little tidal volume it took on an adult to deliver that 400 off that BVM. So keep an eye on that, and I'll bring it up so Lisa doesn't have to. Obviously, end-tidal is going to be key in these patients. Obviously, trying to optimize their end-tidal, get good gas exchange, and that's what it's measuring, and your CPR.
So for those cardiac monitors that do have end-tidal on them now, when we're demoing cardiac monitors and looking at some, can we, if we are just doing rescue breathing, can we hold the mask, or what type of airway needs to be in place? Can we have somebody on a nasal cannula that we're assisting ventilations and have them on the capnography nasal cannula, have a background mask over their face and ventilate them?
If we're bagging, we can use the inline bag
Okay.
for either tube or BVM.
Okay.
It's all 15 millimeters.
So they don't have to be necessarily intubated
No.
or have a king airway in place to utilize capnography. Okay.
Right.
All right. So now let's go into taking care of the patient. So that's kind of the BLS review. Let's go into AHA's systematic approach of evaluating your patients, identifying what's going on with them, and then making that intervention. So yes, it's the initial from the door assessment, and then you go into the primary and secondary. In the PALS book, discuss diagnostic care and things that the more the hospital's going to do. But what it's going to be difficult during the mega code process to explain what a sick kid looks like. But what does, that's what I'm asking you guys to do. What does a sick kid look like to you during that initial impression? Now, from the door, what makes Josh Mifflin and Rick Weiss go, okay, this is legit, we have a sick infant, we have a sick child?
My number one is, are they tired and can they hold their head up?
Okay.
Because when you think about what causes a lot of cardiac arrests in pediatric patients, it's respiratory. It's something respiratory in nature. So when you think about the bridge between respiratory distress to respiratory failure and to eventually cardiac arrest, fatigue is one of the big things that kind of bridges that gap between respiratory distress to respiratory failure. And from respiratory failure to cardiac arrest, respiratory arrest, cardiac arrest, there's not a very large window there. So the first thing I want to do is see if the kid makes eye contact with me and if they look like they're getting tired, or if they say they're getting tired. Anybody who's got a respiratory condition, especially a kid, or a respiratory issue, if they're starting to get tired, if they look like they're starting to fatigue, if they tell you they're getting tired, you really need to pay attention to them. And that's on top of just general color and kind of your gut feeling. But those are some things that I look at. Get the color, and then just kind of look at their overall, do they appear to be exhausted? If they're starting to hang their head and starting to say they're feeling tired, I'm really starting to worry about them and need to intervene relatively quickly.
Okay.
So we just don't run the volume of pediatric patients, so it's hard to get a good idea of what a sick kid looks like, right? So our adult patients we go to every day, we walk in and go, yeah, they're sick, right? But when you're only seeing 5 pediatric patients a year maybe, then it becomes a little bit more difficult. With that said, the more you look at your pediatric pediatric patients and the more you study your pediatric patients, and especially for the members on the job that have kids at home, it becomes easier to recognize.
Okay.
But like Weeks was saying, you walk in there, you go, hey, what's going on with my kid? And it is truly from the door. I mean, the book, your doorway assessment, part of your PAT is that first initial, what do you see?
So the PAT is up there, but just so everybody knows, PAT is the pediatric assessment triangle. Appearance is the big one that we're looking at, and then work of breathing and circulation. So
So
let's talk about appearance, but how do you guys measure work of breathing and circulation?
Yeah, so the appearance, I'll start there because the appearance is key. When you walk in and they don't make eye contact with you, and you make it all the way up to them and they're not paying any attention to you, there's a problem, right? Kids should be a little bit apprehensive of strangers walking up, at least make some attempt to interact with them. And then you get to breathing. If breathing is noticeable, there's a problem.
Okay.
If we're sitting right here, the entire video, I bet nobody's paying attention to our breathing because it's not noticeable.
Yeah.
Right? But once it becomes noticeable, there's a problem. If you're noticing the breathing, there's a problem. And then circulation, right? So then you get into cap refill times. That's a big one with your pediatric patients. Your brachial pulses, not necessarily radial. Central cyanosis. Are you seeing retractions with the work of breathing? All that stuff starts forming your picture of this kid. And then you go, okay, what's going on?
All right.
What's their complaint?
So that's when you get into we've walked up to them, now we're into the primary impression.
Yeah,
right. First step. So we've all done the ABCs. In PALS, we add D and E. So airway, breathing, circulation, I think everybody understands. And the moment that you find that they're not breathing or they don't have a pulse, yes, we're going to change over to the CAB and focus with compressions. But during the assessment, ABCs, I think most people get. You guys can talk about how you're going to assess those. But then the disability, that might be one that, what do they mean by disability and exposure for the E? What does your pediatric assessment on the A, B, C, D, and E look like? And
so with disability, that's where in my mind, that's where I'm going to check things like blood sugar. I'm going to kind of try and get a little bit more of an idea of what the underlying condition is during disability. Not a full-fledged assessment, but just kind of some of those diagnostic things.
Okay.
Well, is there a recent seizure? Have they fallen in their heads recently? Do you have a fever? Are they dehydrated? That's the stuff that you start looking into for your disability because it's more central nervous system.
Okay.
Right.
And then exposure. Well,
I think exposure goes back to work of breathing. It's really, depending on what the kid's wearing, really exposing their chest, obviously if conditions dictate, and being able to see their intercostal muscles, being able to see their diaphragm, being able to see for central cyanosis like Josh was talking about. So really getting a full assessment of your patient.
And we don't want to leave out too big time with pediatric patients with rashes, bruising, stuff like that. That we're not necessarily getting called for a trauma patient, but it's a pediatric patient. Maybe you're not getting the whole truth from the parents.
Okay.
So let's keep an eye out for that.
all right. So almost in the pediatric population, you've got to at least think about the possibility that there's some type of trauma, or kind of treat them like an adult trauma patient, where we would go somebody that's been ejected from a vehicle and not trauma stricken and not look, but we need to kind of do that with our pediatric patients.
Right, understanding that they might not be able to tell you exactly what's wrong. So trying to get a full picture without them being able to tell you what hurts, what's bothering them, things like that.
All right. So that's the primary impression, and now we'll get into the primary assessment and the secondary assessments. We're going to do our sample. I think it's important for everybody to know when they're doing their mega codes, if you follow this and go through and say, what does the kid look like as I'm coming in, that we'll each try and do the best job we can giving that scenario. But then ask, is their airway open? Are they breathing? What's their pulse rate? What's their circulation? Do they have a disability of any type? And I want to expose them and see what it is. And then get into the sample history of signs and symptoms, allergies, medications passed, medical history, last 4-1 taken this part. I'm glad I remembered it. But then vital signs. Is this where you guys would add in vital signs as well?
Yeah, I would be getting vital signs at some point during your sample. Okay.
And then as you go through, so if we are going back up and we find that we're at B, we don't think that they're breathing, we don't have to then continue going through and C and then D and E and all of that. we've identified it, and then now we're going to intervene.
Yeah, airway problem, fix it. Breathing problem, fix it. Circulation problem, fix it. So on and so forth.
All right.
If you progress down through it, good. If not, stop, fix it.
Stop and fix it. So as you find some of these things, go ahead and fix it. The next thing is team dynamics, and that's a big part of the video, and they show the code where the ambulance comes in and the patient's still strapped to the cot and all of those things. And while that is probably the worst thing that could happen, we've all been on calls where one or two of those do occur, where there's not the mutual respect or clear messages, or you may, hey, give me epi, and somebody gives you the wrong concentration of epi. So those are important. But what are, out of the team dynamics, well, most people gloss over when we're talking about that, or they're watching a video, what are some real benefits from this part of the team dynamics that you guys think that we could incorporate into our, not only our pediatric arrest calls, but our adult cardiac arrests as well?
Go ahead, we touched on it earlier. That's good.
So I really think that, I think collectively, especially with the higher level of care that we're starting to provide and the more eyes that we have involved, I think it's important that the one person at some point throughout that arrest, regardless if it's a pediatric patient or an adult, kind of takes a hands-off, kind of outside looking in approach to make sure that everything is working the way that it should. You know, we talked about the pick crew approach, and there should be somebody designated for that role with a pick crew approach, but I think sometimes we get so focused on completing a task, whether it be managing the airway, getting IV access, doing CPR, running the monitor, that we forget that there can be a lot seen from the outside looking in versus whoever's trying to start an IV, calling out orders to somebody running the monitor or at the airway. You can have somebody really quarterbacking the whole situation and saying, hey, you know, your chest compressions don't really look deep enough. Why don't we either think about correcting them or getting somebody else in there? Or, hey, we've got, on my notes here, it's been about 3 minutes since we've given epi. Let's think about getting another round of epi in, or another drug, whatever the situation may be, or, you know, monitoring tidal volume, ventilations, like we talked about. I think people grossly underestimate how important ventilation is and not hyperventilating the patient. So having somebody taking that outside in look and being able to kind of be the eyes of the whole scenario is huge towards overall team dynamics.
Okay.
And if you get a situation where I'm really struggling to get an IO or IV or struggling with the airway, then maybe Josh and I can switch. I can take his role, I can take his notebook and say, okay, I'm going to take this outside in approach now. Josh is going to come over and he's going to get a line, and we kind of continue where we left off. So closed loop communication and kind of going through one quarterback, if you will, for the situation.
Yeah, I like that. Well, just there's one quarterback that's making those calls while we're doing it.
And once you get to that position and once you get comfortable in that position, you'll be bored.
Right.
I mean, you truly will be bored. You're stepping back, so really you're looking at the entire scenario, and then you're running the call, right? So it's out of your hands to get in there and get the airway, and get in there and get your IO and get the drugs and whatever. That's kind of out of your hands, and it can be extremely frustrating, especially when you want to be the person doing it. And I think we kind of are all wired that way to where we want to get dirty, we want to get our hands in there, and we want to perform the skills, but to play a bigger role, step back and go, all right, this is my responsibility for this call. This is what I have to do. It makes a huge difference. That way, when ALS gets there, it's the same idea. They kind of get the report from you, and then they kind of step back, and at that point in time, you go, okay, how can I help? Maybe you write in. Maybe you find something else to do. ALS runs call.
And I'll use a personal experience just real quick. Was my first time in that role, I just fell into that position where I was kind of the one standing back, kind of coordinating things. And along with that came talking to the family and explaining every step of that situation to the family. And it made an impactful difference. You know, they made mention of it before we left, that thank you for doing that. You know, I understand what's going on. I understand the severity. You know, thanks for explaining the process. So, I mean, that can be worked into that too, talking to the family and trying to gather a history or whatever.
Okay. All right. Perfect. And if you find yourself not having anything to do, you can always start to review the H's and T's. You
Absolutely.
can never enact too many H's and T's. All right. The way the mega codes will run with PALS is that there's technically 2 mega codes that every student's going to go through and have to do. Some elect to do their 2 as a single long mega code, but for every one of those, there's going to be either a respiratory or shock case, and then a cardiac arrest mega code. So let's go through what those respiratory emergencies are. You guys will have free reign of the board. You can sit and talk. You can go through what each of them kind of are, what's going on inside the body, and then what care, both AHA, because it's important as this is a PALS review, but more importantly, if we're going to spend the time doing some training, what is it that we can take from watching this video and apply to our pediatric patients that we're going to run calls on real life? So I don't know which one of you guys wants to start, but we'll have disorder controlled breathing first as a respiratory emergency.
And I'll go ahead with that one because there always seems to be quite a bit of confusion with disorder controlled breathing on what exactly it is and so on and so forth. And it's really simple. It's anything neurological. So if you think about it as something that's neurological, then that's going to be disorder controlled breathing, whether it's a seizure, whether it's a recent head injury, whether it's exposure to toxins that now they have an irregular respiratory rate, and that's what it's all based around is irregular respiratory rate. If you keep it broke down to something that simple, you'll do just fine on the test. And that's really what you're looking for when you see pediatric patients too. Anything irregular with central nervous problem, system problem, disorder controlled breathing.
Okay. And what's the care going to be? We're just going to...
Good point. Depending on how severe it is, remember most of your pediatric arrests are respiratory in nature, so you want to fix that. If they're not oxygenating or ventilating them. If they are maintaining their airway and they're getting good oxygen change, maybe it's just something we need to monitor, put them on some O2.
Check the blood sugar?
Let's get our blood sugars. Okay. Normal stuff we're doing on every patient, let's just make sure we're paying attention to it and doing it with these.
Okay. Anything to add?
No, I think you covered disorder controlled breathing. That was one that was always confusing to me. I always read that and I'm like, what do they mean by this? They added it a few years ago and I remember reading it on the test going, and I mean, that's
central nervous system.
Central nervous system, yeah.
Okay. Lung tissue disease.
So lung tissue disease to me, this kind of, when we're talking about pediatric patients, I think about some type of infection in the lungs, whether it be pneumonia or some other type of infection, or cystic fibrosis, or really anything that when you talk about the lung tissue and the role of the lung tissue, it's to diffuse oxygen into circulation. It's how we get oxygen to bind to hemoglobin to be sent throughout the body to the rest of our tissue. So in order to really correct some type of lung tissue issue or something impeding that transfer of oxygen into circulation, you need to increase the percentage of oxygen that's delivered. Okay. So very simply put, it might not necessarily be a non-rebreather that does the trick. It might be a nasal cannula, but we need something that increases the amount of oxygen in the lungs, thus making it more available to diffuse through whatever lung tissue disease there is and get into systemic circulation. Generally, we guide that therapy based off SpO2.
Okay.
So then we get to lower airway obstruction. Think about lower airway as anything below the blood opening. So anything below the vocal cords is going to be your lower airway. So asthma, lower airway. COPD, lower airway, which we're talking pediatric patients. So COPD is probably not going to be your big one, but anything lower airway. Pneumonia, trying to think of some of your respiratory lung tissue disease, lower airway, but anything past that blood opening.
So you said, so your lung tissue diseases are in the lower airway, but if you get a mega code that talks about you have a patient that has asthma or wheezes,
yep,
that's actually counting as an obstruction.
Yes.
Okay. So
yep.
what do we do for that? Sorry, I cut you off.
No, that's good. So for your asthma, okay, we can do a neb. All right. So it's all based back to your protocols and what you can do in your protocols, and you're just following that. Okay. For lower airway, it's pretty straightforward. We're basically looking at nebs or positive pressure ventilation if they're like a drowning or near drowning victim, we're looking at positive pressure ventilation to push the fluid out of the alveoli.
Okay. When we go through and listen, and I'm cutting you off before you get to upper airway obstructions, but if I'm listening to lung sounds, will I hear something that's going to tell me lung tissue disease or lower airway obstruction?
Yeah.
So I know you said wheezes for lower airway, but is there any other thing that we can listen for and go, oh, this is what it is?
Basically, any abnormal lung sound is going to be a lower airway disease or obstruction. So if it's bubbling or crackles or rails, or if it's wheezes, if it's, if they sound wet in the lower lobes, and we're start looking at pneumonia, any abnormal lung sound is going to be lower lobe.
Okay.
Or lower airway, sorry.
Yeah, I think it's really important to assess the lung sounds. It'll paint with what little we have to use pre-hospital. Listening to lung sounds is really going to steer you down a path of how to treat a lower airway obstruction, something like asthma or some sort of infection.
Okay. When we get to the upper airway, now we're up in this part, we're not going to have lung sounds that are going to guide us. Now there could be some, but not. What is that we're looking for?
So with upper airway, that's going to be your Matchbox car, your some type of obstruction in their throat. They're choking, or food, or even some types of infection like epiglottitis can affect your upper airway, can swell your throat shut. So that's another kind of anatomical difference with pediatric patients than adults, is they don't have a whole lot of room to lose in their upper airway before they start really restrict airflow in and out of their lungs. So it doesn't have to be huge to restrict air movement.
I'll add to that real quick. If you're hearing stridor, so we talk about upper airway sounds, and we're talking about stridor, and if you're hearing stridor, 50% of the airway is already occluded, so you're well behind the eight ball.
Right.
Okay.
And I think personally the biggest thing with upper airway obstructions in kids is if it's not, if they're to the point where they're still thinking clearly, they're still talking, they're still looking at you, their color is still okay, don't mess with them. Don't make them mad, don't irritate them, don't make them cry. They go to the hospital how they want to go to the hospital, if it's on mom's lap, if they want to ride on the roof of the ambulance, whatever. Don't make them mad, because you make them mad and they start crying, that's when that situation goes from bad to really bad, really quickly.
Pediatric patient crying is 30% increase of work of breathing. So you've taken a pediatric patient that's already upset, has some maybe airway obstruction with epiglottitis is a huge one that you don't want to make them cry, and then you make them cry, you've just increased the work. You've made it worse.
Okay.
You've made it worse.
So do whatever you can to keep them happy. And we probably don't have the equipment and the tools needed to manage their airway the way that they need it managed. So just get them to the hospital without making it worse, which means don't make them mad.
Anything else you guys like to add on respiratory emergencies before we move on to shocks?
Snoring, tongue.
Okay.
That's a big one. Most common obstruction, upper airway obstruction, is tongue. So, add that in.
All right. Okay. So, hypoperfusion, aka shock. Multiple different types, different stages. So I'll just kind of do the same thing with you guys and let you go through, and let's talk about each one, what it looks like, how we tell which one it is, and then what we're going to do about it as both advanced providers through PALS, but then what we're really going to do when we go on these calls. So.
Okay, I'll go with hypovolemic. Hypovolemic is just volume, okay? Volemia, volume, that's what we're looking for, is hypovolemic shock. And that could be from numerous things. It's not necessarily that they're just bleeding out. So I think that's a misconception that we all get, is that, well, they're not bleeding anywhere. It can't be hypovolemic shock. But especially with pediatric patients, it can be when you start talking about, have they been sick recently? Have they been running a fever? Have they been thrown up? Have they had diarrhea? Do they have wet diapers? That's going to be big key-ins on if they have adequate volume. Also, you can start talking about their blood pressures and so on and so forth. With that being said, I'm realistic, and I think we get blood pressures on a lot of our pediatric patients. So be looking at your cap refill. What's their skin turgor? What's are their fontanelles sunken in? Are their eyes kind of sunken in? What's their gum line look like? Is it good and pink? Are they showing signs of cyanosis where they shouldn't be? But yeah, so hypovolemic could be because of blood, but it also can be because maybe they vasodilated out. Maybe they have been crapping and, haven't been able to keep any fluid down for a period of time.
And so what's our number one care for that going to be then?
Volume
Okay.
replacement. Yeah. So get an IV started, and then it's going to be 20 cc's per kilo for your initial boluses, unless you suspect it's cardiogenic shock, and then dial that back. So just think about your CHF patients. You don't overload them with fluid.
Right.
Do the same thing for your pediatric patients that
Okay.
have a bad heart.
And then looking at, so coming up with sizes, I'm not probably as good as Rick at picking pediatric sizes. So,
Off by 6 kilos.
So what tool do we have that, I think everybody's gonna say, hey, where's it at on the rigs? Understanding, that's one of the things that I try and look for the days that I am on, but we have it on the trucks now too. But finding that Rosso tape and going through and measuring them. So when you say 20 cc's per kilo, you just have to be able to know where that tape is.
Yep.
And figure out how many of those
And it's even on there.
on there,
On
on
your
all your drugs. So
And it's been made really easy for us. We're really fortunate that we've got those Thomas bags, and inside those Thomas bags have cheat sheets for really to the point where it even simplifies this to all you have to do is find the patient's weight, and then those cheat sheets give you the exact dose that needs to be given. So, trying to sift through all of this stuff has been streamlined even more because of the fact that it is a high-risk, low-frequency event. We want to minimize all the chance for mistakes.
okay. Cardiogenic shock, you're just kind of talking that's
So, cardiogenic shock, I think we think about it being one thing in adult patients. In adult patients, we think of cardiogenic shock being heart failure caused by some type of cardiac event, whether it be an MI or whatever, generally a heart attack. In kids, it's a little bit different. So part of the development of a child from birth is closing of holes in their heart. And some kids typically will take longer than others, but it's important that those holes close. In some cases, those holes don't completely close. Sometimes they're called murmurs, sometimes you hear them called cyanotic defects. Things like patent foramen ovale is one, where it's just a hole linking the two sides of the heart, and it can cause issues later on down the road, especially through like strenuous activity, things like that. Kids can exhibit the same way an adult who's had a previous MI. So they can become hypotensive, they can have fluid in their lungs, they can appear to be cyanotic or hypoperfused or hypoxic, however you want to put it. And it's important that we correct those, but like Josh made mention to, if their blood pressure is low, flooding them with fluid is not the answer. Their heart is already in a state where it's not handling the amount of fluid that it was already getting, and you just adding more fluid to it in a large quantity, something like 20 milliliters per kilogram, is not the answer. All you're wanting to do is just help their perfusion, so that's why we decrease the amount of fluid that we give. The best person to talk to about that is probably going to be mom or dad. They're going to understand, well, the doctor said they had a murmur at their last checkup, or when they were born they spent time in the NICU for whatever. And there's several different ways to treat those nowadays. But kids still go home with them. They still can pose an issue down the road. So it's important to get mom and dad involved.
okay.
Too.
Distributive shock.
So we get into distributed shock. This is going to be like the kids are outside playing a soccer game, get stung by a bee, and then they go into an anaphylactic shock. Okay, so that's going to be your distributed shock. Kind of misspoke earlier of hypovolemic, where I said they vasodilate out. That's going to be here with distributed. Okay. So hypovolemic is strictly a volume problem. Distributed is a container problem. Okay, so their container's gotten bigger. They don't have the volume to support the bigger container, and their blood pressure tanks. Biggest one, anaphylaxis for your pediatric patients.
Okay. So EpiPens.
EpiPens, right? Yeah,
Or
or treatment,
draw, take
EpiPens,
The,
don't forget your albuterol with those patients
Okay.
too. You know, that's gonna be something to keep in your mind too.
Kind of bridging over into obstructive shock. Obstructive shock really comes down to two things: cardiac tamponade and tension pneumothorax. So it's something that's obstructing the ability for the heart to push blood forward.
Okay.
So when we think about a tension pneumothorax, we think about a lung collapsing, filling the chest cavity with air, shifting everything over. Because of the accumulation of air, you're shifting everything over, collapsing the heart, decreasing its ability to push blood forward. And then when we talk about cardiac tamponade, we're talking about fluid filling the sac around the heart. Again, you have your pericardium, which is the sac that the heart lies in, and you have vessels around the heart, as we know. And if anything were to lacerate the heart muscle or something like that and starts to fill that sac, then it starts to squeeze the heart, again, decreasing the heart's ability to push blood forward.
Okay. One that I know that is on the exam is they want to talk about, hey, when do we recognize sepsis? So where does sepsis fall in the shock? So where do we see septic shock? And then our care for that is probably more or less going to be your fluid replacement. But they want, and what we do with our adult patients with our septic alerts, is that early recognition. So if we think that we have a septic pediatric patient, letting them know, and that's really so that they can start antibiotics.
That's gonna be big.
So for a test question, yes, antibiotics is what we want to start. Since we're not carrying any antibiotics on any of the rigs, I think it's more of like an understanding that early antibiotics is going to help out. That's what you're going to want to give.
And that's our goal for any kind of septic patient. I mean, the decrease in mortality with early antibiotic therapy is huge. So, but yes.
All right.
Yeah.
Perfect.
And that's going to be more of a distributive shock.
Distributed. Okay.
Yep.
So stages of shock. So we just talked about different types. Now, how are we going to say, hey, they just are starting into shock, or they have been going? We've all heard throughout our careers, on how children compensate, and then they go into decompensating. And then, so you read through the PALS book or you watch the PALS videos, and they don't have decompensated shock anymore. They've gone over and now they use hypotensive shock, which for me makes it a lot easier. That, how do I know they go from compensated to the next stage? Well, they just change the name of the next stage to hypotensive, so that I know, hey, it's based on their blood pressure. So that makes it another test one. The blood pressure is the number one way that you're going to be able to tell, the number one vital sign on what stage of shock they're in. So just kind of going through that formula of, age and years. Again, I think as you said earlier, we're not checking a lot of blood pressures, but if we think our kids are sick, I think it's super important that we do go through, check that blood pressure, because we need to know what normal is. So you take their age and years times 2, add it to 90, so a 7-year-old times 2 would be 14. He needs to be 104 systolic to know that you're still in that compensated range. As soon as you do, on that same 7-year-old, 14 to 70 and get 84, if that systolic number drops below there, now we know they're in hypotensive. So they've gone from compensating, now they're into that decompensating, and then going away is the low BP, low heart rate, and all of those as they go through. But just understanding what those numbers are, and it only works for ages 1 to 10. So if they're a 9-month-old, if it's less than 70, then that's bad. And if they're over 10 years old, then if it's less than 90, then it's bad. So.
And remember, I'd like to add that when we're looking at this, it's compensated. Increased heart rate, that's going to be for anybody, because it's cardiac output equals heart rate times stroke volume. So as soon as your stroke volume starts to drop, your heart rate will go up to maintain your cardiac output, right? So if your heart rate, you're starting to see patients that are non-cardiac related high heart rates that are suspected trauma patients or suspected shock patients, start fluids. Don't start fluids based off of strictly your blood pressure, because that's just, you're going to be finding out 8 ball games.
Okay, because it's a late sign.
It's a late sign.
Okay, so look at that heart rate and respiratory rate, and if they're not tied together, if your heart rate's super slow and your respiratory rate's super fast, or your respiratory rate's really slow and your heart rate's really fast, there's another issue there as well. So that's not up there, but I think that's important.
Absolutely.
That's my simpleton truck way of going, hey, these things don't match. Something's wrong.
Yeah.
And you have to sift some things out with heart rate too. Heart rate's kind of a subjective vital sign. You know, if you've got a kid who's crying or anxious, or their heart rate's going to be increased. But I really think it absolutely needs to catch your attention and increase your index of suspicion if their heart rate is elevated.
Okay.
Definitely, like Josh was saying, that's going to be your tell for whether that patient is compensating or if they're not. So
We've all seen it too, where we go, well, their blood pressure's okay, but they're really tachycardic.
right.
I'm not going to give them a bolus because their blood pressure's fine. Well, no, their blood pressure's fine because they're tachycardic. They're maintaining cardiac output through heart rate.
That is,
So, and then that's why they crash, right? Because then they go, ah, shit, I'm wore out.
Yeah.
There they go. So, yeah.
perfect. Okay, everybody's favorite stuff. Going through the cardiac arrest algorithms. So the way this will be set up now is that you're going to see several, and just kind of the two of you guys can walk through them just sitting here. And then when we get all the way done, we will do a mock mega code with that kid there, and we'll do that. So I don't care which one of you guys. I mean, asystole and PEA. That's what we'll start with.
So asystole and PEA, I think in my mind this is kind of an easy one because we're thinking about CPR and good continuous CPR, making sure that obviously we're going to want to get our rhythm checks in when we need to at the appropriate intervals, but really making sure we're focusing on high quality CPR. And then epi is going to be your drug of choice. So knowing that PEA is a lot of times associated with hypovolemia or hypoxia, those should be two things that you really think about that are pretty high on your list of H's and T's.
Okay.
So fluid bolus, and then making sure that we have not necessarily an advanced airway, right? Don't get so much tunnel vision thinking that you have to get an advanced airway, but you have to have a patent airway, meaning good positioning, and then good adequate ventilation.
Okay. So just because our patient initially, in that first 5-6 minutes on scene, we don't have to worry about necessarily getting, well, we're not going to intubate a pediatric patient, or a king airway, but a nasal airway or an oral airway, as long as we're getting good chest rise. Okay.
Absolutely. As long as you've got good compliance with the bag,
Okay.
and you've got good chest rise and fall, and you've got the patient in a good neutral position, then I think ventilation and
So really that comes down to high quality CPR, IO, it's a little bit quicker, so they want IO over IV in cardiac arrest or high acuity calls, and then the H's and T's. So let's review those H's and T's real quick, if you will, just so we make sure, and we'll probably do it in most of them. So you already said hypovolemia, we're going to take care of with fluid, and hypoxia, we're getting good airway compliance. So what's another H?
hydrogen ion, so that's acidosis.
Oh, perfect.
Yeah, acidosis, so
Alright.
pH below 7.35 for whatever reason.
Okay, which we can't check.
We can't check that,
Alright.
right? That's when,
What's the hypoglycemia?
hypoglycemia,
that
so
one?
checking blood sugar.
Blood sugar, okay, fix that.
Hypo or hyperthermia is
Okay,
going to be another H.
alright.
And then,
Too hot or too cold?
yep, what's another H?
Everybody's screaming at the computer screen right now, yelling what they all are, because
Right.
Hyper.
Hyper.
there we go.
Kalemia. Yeah, so hypotassium.
Okay,
And then it's hypo or hypercalcemia in there as well,
You can
or not? But
yeah,
You just think about
we can just keep adding all types of H's in there, but yeah, alright, so but blood sugar,
blood sugar,
oxygen,
oxygen,
hot or cold,
hot or cold,
and fluid.
and fluid.
Perfect.
Yep.
The ones that we can take care of. Now, we can, when we get into the T's here in a second, we can work people down so that, hey, this is what we think, but really reversible that we can take care of those. Right. All right, so T's.
it. Toxins, pediatric big toxins, suspect the unexpected. So, they're in the bomb pills, they're in drinking drain cleaner, they're drinking whatever, but toxins,
Toxins.
big time for toxins, okay? Then we get into tamponade, which is not very likely with your pediatric patients, right? I mean, that's probably not, but potentially, right? So we can throw trauma in there, I guess, you know, so, tension pneumo, okay? Let's see. Thrombosis, pulmonary, coronary, which again, we're talking pediatric patients, but,
Could or could not.
and again, that's one of those that they gotta get to the hospital.
Yeah.
And then, tamponade.
Okay. All right. So again, just reviewing those, but those 4 H's are the ones that I always beat people up on. Is that hey, those are the ones that we can really take care of,
Toxins, you know.
and then toxins. So understanding what it is, and then that person, that code commander that's sitting back, can always be thinking about, hey, can I get some of that information? So
Right.
that you're always doing something.
It goes back to, you know, tension though, trauma, tension, pneumo. You know, as code commander, you sit back and go, hey, do we have lung sounds on bilateral lung sounds? Oh, no, they're excellent. Okay. Let's pass that long ALS. Let's get ready to decompress and
Absolutely.
get a roll. Yep.
Non-shockable.
Non-shockable.
Asystole PEA, so nothing to do with the cardiac monitor as far as, I mean, we want to have them on fast patches and stuff just in case. Hopefully we do get them into a shockable rhythm, but this, no shocking.
Push epi always.
Push epi always.
PEA.
Oh, okay. Yeah, that's
Heard some other ones use a different word, but hey.
All right, so SVT. SVT ranges are going to change from just being a tachycardic rhythm when we get into PALS over 180 for children and 220 for infants. But go ahead on what our care for SVT is going to be.
Okay, so SVT, in this one, we can start with what I normally do with my patients is, do we have a pulse or not, right? Because if it's showing SVT and there's no pulse, then we're back to PEA.
PEA.
Okay, but we're going to assume that they have a pulse. It's too fast or too slow. SVT is going to be too fast. Regular or irregular, it's going to be regular. And wide or narrow, it's going to be narrow. So right off that, I know what algorithm I'm in. My SVT algorithm, that's shooting me that way just based off of those 3 things up there, or 4 things. You can see the rates up there. And that's just going to be based off your monitor, what's going on with your monitor. BLS methods for a youngster, whether it's having them blow into a straw, trying to get them to vagal down, taking a cold pack and putting it on their face real quick, trying to get them to vagal down, taking cold water or a cold, wet, icy cloth and putting it on their face and trying to get them to vagal down. That's what all that's coming down to. If we can't convert them getting through vagal maneuvers, then we go, if it's stable medicine, unstable medicine, and that goes back to 0.2 of adenosine per kilo. So remember, all your medications for pediatric patients are based off of kilos. So 0.2 milligrams per kilogram for your initial dose. And then if it's unstable, we'll just go straight to cardioversion at 0.5 to 1 joule per kilo.
Which at the ILS level, synchronized cardioversion for a pediatric patient,
We're not doing it.
as of now. However, it's important to understand that if you hear ALS coming, that, hey, let's get this, we can start getting them ready for synchronized cardioversion. The other thing on all of these medications that we're going to give up to the adult dose. So when you're pushing epi and you figure out and you get over a box, maybe stop to think, well, Cormac said I just get 1 box, so I might not need 6 boxes of epi based on my calculations for the first dose. So
And remember, it's all.
it's written there.
So don't use your resources that are available.
So it's good. So also now into VTAC, and VFib's going to be up next, but VTAC.
So with VTAC, like Josh said, this is the easiest way to kind of get yourself down a path for success in these scenarios, and taking care of patients in general. Is it too fast or is it too slow? Is it regular? Is it irregular? For this one, just like the last one, it's going to be too fast, ventricular tachycardia. It's going to be regular. It's going to look like an organized rhythm on the monitor. It's just going to be wider than, say, SVT. From there, we get to wide or narrow. In this situation, we're going to be wide versus narrow. So now we need to check for our pulse. So in this situation, we can have a pulse or we may not have a pulse. You can either have perfusing VTAC or non-perfusing VTAC. If there's no pulse, we want to run it just like an arrest. We want to get on high quality CPR. We want to start ventilating. We really don't want to delay defibrillation. So if we show up on scene, we want to be doing CPR as we're putting the pads on. From there, we're going to defibrillate. If there's no pulse, we're going to do 2 joules our first round, and we're going to increase that to 4 joules per kilogram our second round. Again, use your Broselotate. Make sure you're using that, or use the cart that's in the Thomas bag. It's gonna get you down. It's gonna really streamline the whole process. And then we're gonna go to epi, and then if again calculating it the same way, 0.01 milligrams per kilogram. And then we're gonna run it at intervals just like we would an adult arrest. And then our first line antiarrhythmic is gonna be lidocaine. Lidocaine is easy. It's a weight-based drug for adults and kids. Nothing changes. It's 1 milligram per kilogram whether you're an adult. It's 1 milligram per kilogram whether you're a child. So that's how we're going to run that algorithm, and we're just going to alternate those drugs, epi, lidocaine. Okay. So that's for no pulse. Run it very similar to the way we run an adult arrest in VTAC. For stable, or for a patient who has a pulse, now you're looking at, you've got a too fast rhythm, it's regular, it's wide, so now we want to go, are they stable or unstable? If they're stable, we want to get on the phone, we want to call a doctor and see what they want us to do. If they're unstable, that's where we go straight to Edison medicine, we synchronized cardioversion, and we want to do that at a lower dose than what you defibrillate at. We defibrillate at 2 joules and then 4 joules. We want to do that at 0.5 to 1 joule per kilogram. Again, utilizing the sheet that's in the Thomas bag.
And unlike when we are going to ventilate and we've said, hey, pick a smaller BVM if you're on the fence. For me personally, if I want 17 joules and my monitor only do 15 or 20, I'm going to use the higher
Probably
joule
go to
setting.
20.
Okay.
Yep.
All right.
That's what the recommendation is.
Yep.
For
Okay.
age.
So now VFib, similar, but
Yeah, so with VFib, we're going to run this just like we would run a VTAC scenario. So you've got, when you're talking about a cardiac arrest, you've got PEA asystole, which is push epi always. That's where we're going to give epi, CPR, epi, CPR, epi, CPR. That's how we're going to run that one. For this one, we're going to run it just like we ran the wide complex tachycardia or ventricular tachycardia, where we defibrillate, we want hands on the chest immediately. While we're doing CPR, we want to get the pads on. As soon as we get the pads on, we don't want to delay much time. We want to get that first shock delivered and hands back on CPR. So really make sure we get that first shock delivered. Again, we're going to do 2 to 4 joules per kilogram, or 2 joules initially, 4 joules for your second shock. In the meantime, somebody else can be working on getting an IO or IV. One thing I'd like to add to IO is a great alternative to IV, or a great, it's a great go-to initially. But if we have the opportunity, which generally we do, maybe not so much in the pediatric population because we're kind of wanting to get them to the hospital, but in the adult population and pediatric, we really want to look for an IV site. IV that's ideal. IO is a good alternative initially to get those first round of drugs on board. But if you find yourself with a minute and you're next to the patient and you have your bag right there, it's not going to hurt anything to look for a good IV site. So keep that in mind. But then we're going to go back to epi, or we're going to go to epi as your first drug, and we're going to do 0.01 milligrams per kilogram, just like we did before. We're going to do lidocaine at 1 milligram per kilogram, and we're going to alternate those.
okay. All right. You guys are doing great. So VTAC without a pulse, VFib. Only 2 that we're going to shock, but we can shock them as soon as we see them.
As soon
As soon as we see them on the
Yep.
cardiac monitor.
And I know that question was brought up quite a few times in ACLS. Do I have to wait my 2 minutes to get through the cycle? As soon as that monitor gets on them, either weld them, or if it's PA systole, you can just continue your algorithm.
And then after you shock them, straight back into CPR.
Absolutely.
Keep helping out. All right, bradycardia.
So your Brady algorithm, is just a slow heart rate. Begins with your assessment, right? You figure out that they're bradycardic, and most of the time that's going to be because of being hypoxic, okay? So it goes back up to here, right? So your first assessment, do they have a pulse? Yep. Is it too slow or too fast? This one's going to be too slow. Regular, irregular, probably regular for your bradycardia. Wide or narrow, probably going to be narrow, okay? So too slow, regular, narrow, I know I'm in my bradycardia algorithm just based off of that. Now this is where it gets a little bit questionable, like we talked about earlier. I think we did a good job of addressing if it's 60 and they're upright talking to you, we're not going to do anything. If it's 60 and they have signs of inadequate perfusion, then we're going to start CPR. But 60 is that number. They get your IVIO, epi, 0.01 milligrams per kilogram, and that's different than your adult. Okay, so that needs to be highlighted because in your adult patient for bradycardia, it's 0.5 of atropine. With your pediatric patient with bradycardia, it's going to be epi, 0.01 milligrams per kilogram. And then consider your fluid bolus of 20 mLs per kilo, cardiogenic 10 mLs per kilo. Pretty straightforward. If they arrest, then we go to our arrest algorithms that we just did. What do they go into? Do they go into a VFib? Okay, let's shock them. Let's work with our epi. We've got that dose already. And let's start CPR. But again, oxygen via BVM is going to be very significant. Very significant.
Okay. So now I'm going to run you guys through a mega code. Surprise. Two things I want to highlight beforehand though. The drugs for PALS. Really it's epi for bradycardia, for anaphylaxis, for your first round drug during cardiac arrest is epi, epi, epi. If they have an upper airway obstruction like epiglottitis, it's racemic epi. And the only time that you're going to give a drug that's not epi, it's lidocaine, or in the PALS world, amiodarone at 5 milligrams per kilogram. But lidocaine, so epi, lidocaine, and antibiotics if we suspect that. So there's not really a ton of drugs. And then the other thing is we've covered a lot, both at work and in the system, that PICU CPR, stay on scene and do those first several rounds of drugs because it's the same drugs that they're going to give in the ER, and that chance, that high quality CPR, a lot of that goes out the window with our pediatric patients because of toxins and different things. So I think it's important that it's okay, you still have to do high quality CPR, but you don't have to sit on scene with somebody's baby for 20 minutes doing the first 20 minutes. And you can do that en route to the hospital. So
I think that's a slippery slope. I mean, obviously we want to get the patient to the hospital as quickly as possible, but let's not forget that we have the tools to be able to manage the initial stages of a cardiac arrest, right? Once we show up, the emergency's over. That's
correct.
Yeah, that's our job at that point. So it's important to realize we have the tools. So there's no reason as a fire department we should be running out the door with a baby without doing anything to try and throw them in the back of an ambulance. We have the ability to manage some things. You're correct, we don't want to stay on scene as long as we would with an adult, but let's not get ahead of ourselves. Let's make sure we're managing the patient.
So maybe a best of both worlds. Let's get
Yes.
some things done, but maybe not spending 20, 30 minutes on scene.
Correct.
Okay, that's fair enough. We can do that. Which one of you guys wants to be in charge of this cardiac arrest?
You got it.
I guess
All
I
right.
have it.
So we'll kind of just verbalize a lot of stuff because
All
we
right.
have the airway stuff over there. But if you just want to verbalize, and we will kind of go through and let me make it a little more difficult on you guys.
Thanks.
So you're welcome. So you guys are dispatched to a report of a 7-year-old that came in complaining of not feeling well and was having respiratory distress. He's now gone unresponsive, and mom called 911.
Okay. All right. Are you going to play the part of mom?
I'll play mom and anything else that Josh can't do for you.
All right. Hey. What's his name?
Frank.
Frank. Can you talk to me?
We call him
Can you
Frank.
talk to me? He's unresponsive?
He's unresponsive. He
All
kind of moans a little. Like,
Do I have a good carotid pulse?
It's kind of weak, but you do have a carotid
Okay.
pulse.
What's his cap refill like?
It's plus 2 seconds.
Okay. He's got a carotid pulse. What's his rate? Just general?
His heart rate is 45.
45. All right. We're going to go ahead and we're going to start CPR. He's unresponsive. Heart rate's less than 60. We're going to start CPR. He's showing signs of inadequate perfusion.
Okay.
I'm
So you
gonna
have
get a
somebody
good
doing
weight.
high quality compressions right now.
All right. Since there's 3 of us on a company, I'm going to have the other person get the patient into like a good neutral position. How's he at? Is he?
That was just your dad's coming.
That's me.
Is that you? All right. So we're going to put the patient on pads. We've got the patient being ventilated. I'm going to get a good weight. How's his responsiveness with chest compressions?
He does not wake up.
Doesn't wake up. All right. So let's get a weight. He's 22 kilos. So we've got our pads on. They were on.
All right, he's on the cardiac monitor. Since it's not showing up, he is a sinus Brady on the cardiac
Sinus Brady at 45.
We're
He's
live.
hypoperfused. We're doing CPR.
Okay.
So at this point, we're going to get 0.01 milligrams per kilogram of epi. We've got ventilation,
You have the epi.
high quality, or with 100% O2, CPR on the monitor. We've got a weight of 22 kilos, so that's going to be 0.22 milligrams of epi.
Okay. How are you gonna give it?
We're going to give it IO.
How do you do an IO in that pediatric? Because you haven't started it yet.
Okay, so we're going to start an IO in a 7-year-old.
Okay.
We'll go with a pediatric size or pink size easy IO, 2 finger depths below and lateral to the tibial tuberosity. And we're going to start an IO that way. We're going to have fluid running. We're going to give him a bolus of 20 mils per kilo. So we're looking at 440 mils that we're going to give through that IO. We're also going to give the 0.22 milligrams of epi while continuing CPR.
Okay.
0.22 mLs of epi.
Or I'm sorry, correction. It's going to be 0.22 milligrams, which is going to be 2.2 mLs.
Thank you. Yep, gotcha.
Look at that.
Thank you for saying that.
Yeah.
So, all right. So we checked for rhythm. On the monitor, we've got,
It's been 2 minutes.
all right, on the monitor, we've got VFib. We're going to defibrillate. So first defibrillation is going to be 2 joules per kilogram.
Okay.
So we're looking at 40, we could probably only go up in increments of 10, right?
I do not know what that cardiac monitor will do, but yes. That's part of knowing your equipment, paramedic lease, but
This is the Zolt M series. We're gonna get a Zolt X
I
series.
don't know that anybody uses it. Yeah. So
Okay.
what is your joule setting?
So joules are gonna be, we're gonna be 44. If we can't get to 44, we're gonna round up to the nearest number. We're not gonna round down.
All right.
So we're gonna go up to 50 joules, deliver the shock, and we're gonna go right back into CPR.
Okay. So it's charging.
All right, we're gonna continue CPR. We're gonna try and minimize our peri-shock pause. So we're gonna be doing CPR while the monitor is charging. Once the monitor says shock, we're gonna go ahead and deliver the shock.
Okay.
We're gonna get right back into CPR.
All right.
At this point, we're gonna be thinking about H's and T's. We've got a patient being ventilated. We're gonna look, was he choking? Was it potentially anaphylaxis? What was he doing outside?
He was playing. It's a day like it is today. It's kind of winter times. He's been sick
Okay,
as of late, and this was the first day that he started feeling a little bit better. So I let him go outside, and then he came in and said that he couldn't breathe, and he collapsed.
okay. All right, so we really don't know much. It could be some type of infection. He could have been stung, could have been, well, probably not stung, but could have had some sort of allergic reaction to something. Could
It's
have been
emergency,
contact.
Not that we know of.
So at this point, we're kind of trying to rule out some H's and T's. We defibrillated. We're running through our VFib algorithm So we're gonna get,
And it has now been 2 minutes.
all right, so at this point, we've given 1 round of epi. We're gonna stop CPR, check for a pulse.
No pulse?
No pulse, we're still in B-fib. We're gonna go ahead and defibrillate now at 4 joules per kilogram.
Okay.
Correct, yes, 4 joules per kilogram. So we're gonna go 90. Now we're gonna draw up an antiarrhythmic. So we're gonna do 1 milligram per kilogram of lidocaine.
Have you delivered that shock and all that stuff?
We have delivered the shock.
Okay.
So we're gonna minimize perishock pause, continuing CPR until the shock is advised. We're gonna deliver the shock, and now we're gonna draw up our first round of lidocaine.
Okay.
1 milligram per kilogram. So we're looking at 22 milligrams of lidocaine. We're going to give that IO. In the meantime, we're going to look for IV access as well. We're still trying to deliver that bolus through the IO.
Okay. To the magic of time, it's been another 2 minutes.
All right, so at this point, we're going to go back to our monitor, check for a pulse. No pulse, he's asystolic, right back onto CPR. We are going in the wrong direction. So from here, we're going to do high quality CPR. I'm going to drop another round of epi.
Okay.
I'm going to give that other round of epi.
Sorry, I did silence my phone. Okay.
H's and T's for
H's
the
and T's.
essentially PEA. So hypoxia we should be fixing by VBM. Hypovolemia we should be fixing by giving fluid boluses. Hydrogen ion acidosis, well maybe we might be getting there. So hyperthermia, cold outside winter's day, maybe that's got something to do with it.
He was all chilly.
Toxins, we'll be looking at that too. What was the outside doing? Was the outside running around with his friends? Did they get into something? Any kind of traumas, we're going to be exposing, make sure his chest wall equal, lung sounds, for tension, so on and so forth.
Okay. So all H's and T's.
Yep, so we got to our next 2 minutes.
Yes, you have.
All right, so now I'm feeling for a pulse. Looking at the monitor, I've got what looks like an organized complex on the monitor. Do I have a pulse?
You
with
should
that?
be able to feel one. He's a smart man.
What does entitled do?
His entitle went
I do
from
have a pulse.
initially 21 during your high quality compressions. He's now at 40.
All right, so he's got a heart rate of 77. His entitle is at 40, which will probably come down a little bit as we continue to bag. We're going to continue to give him the fluid unless we've gotten it all in which case we might consider a second bolus.
Okay.
Heart rate's 80. Do we get a manual blood pressure?
Yes, you can. It's 100/70.
All right, so his blood pressure is fine. So at this point, we're definitely going to want to transport. Heart rate's coming up. He's 124. Okay, he's fine.
Okay.
He's got a good blood pressure.
Good.
How's his skin color?
Skin color's improving.
Okay. We could get a 12 lead.
What do we call this? What is it
Return
called?
of spontaneous
Return to
circulation.
spontaneous circulation.
So we have Ross.
Let's see here. What else can we do? We can check a blood sugar.
All
We
right.
should have done that during the arrest.
Well, you said the H's and T's, but you didn't really ever take care of that H. So you are
well,
correct. I made note of
you
that.
should have known what I meant.
Mm-hmm.
So, got blood sugar. What's his blood sugar?
It's gonna be 30 now.
75. His blood sugar's 75. So we're good to go.
Yes, it is.
All right, transport to the hospital. Continue to monitor, checking blood sugar or checking blood pressure.
Okay.
Looking at his
You're gonna be all right,
insight,
Frankie.
gauging ventilations. Really paying attention to his ventilations.
The only thing I didn't hear you say, that if I was evaluating you, which you have 200 people that are gonna evaluate.
Oh,
you did
I'm
on that one,
evaluated like crazy.
Um,
What did I miss?
is you didn't clear the patient before you delivered your shocks.
Oh, okay.
So,
Okay. I should
again,
have done
it's
that.
one of those, but you were shocking, so
Oh.
I'm happy about that, but that's as simple and as difficult as they can be. We're going to start each one with a respiratory case, so instead of you just coming up with him and finding him bradycardic, you may walk up and find that he's having severe stridor or severe expiratory wheezes or something like that, I'll let you take care of that for a few minutes, and then you're going to go into your bradycardia case. Or that it's going to be really sick for the last month, mom hasn't taken care of him, because she just has 8 other kids and doesn't have the ability to take care of all of them that great, and you have some type of shock that you've got to take care of for it. So that's kind of what we're looking for. Is there anything to add?
I don't think so. Hopefully this review is helpful.
Yeah, I want to. So, thank you guys for your time today.